Mike Gibson, Carolyn Hendrickson, and we're talking about the Equiox study looking at potential bias in the use of pulse oximeters across different skin tones and ethnicities. Talk to us a little bit about what you found, Carolyn.
Yeah, so our group was interested in understanding some of the biases that were published on retrospective data showing that pulse oximeters don't perform equally well across all race groups. So we designed a large prospective cohort study at a county hospital that's affiliated with the University of California, San Francisco, and we enrolled 632 patients and followed them with coordinators at the bedside observing simultaneously paired ABGs and pulse oximeter readings to try to understand if these biases differed between race groups or between skin pigment groups. And we measured skin pigment with both subjective and objective measurements. And we also recorded simultaneous potential confounders like shock, perfusion index, vasopressor administration, patient movement, location of the probe, and gathered a really rich data set that builds on what's known about the way oximeters work in real world patients.
And what
What we
did you
found,
find?
what's that?
What did you find?
Yeah, so what we found was that pulse oximeters do not work equally well across all groups, but there's some important nuances to our findings that are different from what's been published before. So previous studies suggested that pulse oximeter bias is positive, meaning the oximeter is telling you a reassuring number when your patient might have low blood oxygen levels as measured by an ABG. We actually found the bias in the population was negative in our health system with one oximeter brand and monitor. And also under normal circumstances, like usual ICU care with normal ratio and normal response to patients, we actually had fairly high ranges of SpO2s and SaO2s, which is typical of ICUs. There's someone there rescuing the patient. So we had very few hypoxemic patients, as opposed to the studies that were published during COVID. So with those important differences in patient population and sort of system level stress, we found that the oximeters actually were reading lower than the arterial blood gases in most observations. Importantly, in 20% of observations, that was not true. We had positive bias. And those positive biases were more or a higher proportion of them were seen in darker skinned individuals and also patients who are identified as African American or Black.
So,
So
so put that into simple language for me. So are we more likely to overestimate how oxygenated Black patients are with the oximeter?
yeah, so in some patients, we are overestimating their arterial oxygenation using this non-invasive technology. But who exactly is that patient is that's having the falsely reassuring high reading is really hard for clinicians to assess at the bedside. So our findings, I would say the important thing is there's probably more uncertainty in how these devices perform than bedside clinicians may appreciate. And it's also hard to know when they're not performing well. And some of the algorithms in the monitors that adjust the waveforms you see as the bedside clinician might lead you to believe the oximeter has more certainty than it actually does. And so our next round of studies of these data and hopefully future larger cohorts is to understand which patients have more uncertainty in the reading. My suspicion is that it's going to be people with perfusion differences and shock and a low perfusion index, which is a number provided by the machine on the monitor. And so we are working to understand the science that clinicians can use at the bedside and also to help inform regulatory decisions around when should a clinician be alerted that the oximeter has a lot of uncertainty and that a blood gas might be essential in helping to make treatment decisions for this person.
Great. And that seems ripe for AI kind of assessment. Is it true for all the different manufacturers or, is there heterogeneity among the different manufacturers of the devices?
Yeah, that's a very important question that we couldn't answer because we were using our standard of care probes, which is a Massimo device in our hospital. But if you look at the literature, there are a lot of manufacturers, and there does seem to be difference between the different brands. These differences are small, but at a population level, it's probably important to understand how different devices perform differently. They are all regulated the same, but we might see different performances based on different technology and different algorithms for waveform interpretation.
Important question. Carolyn, thank you for shedding light on this, something I've always wondered a lot about. Good to see more definitive information. Thanks for sharing with us. Look forward to your future work. And thanks to all of you for joining us here live from ACC 2025.